Hello again. It's good to be with you all for another one of the C-SPY review lectures. Again, my name is Grant Comstock. I am the Associate Medical Director for the Wisconsin Poison Center. I hope you're all doing well with your studying so far. I know this is an awful lot of information to be taking in. I'm sure you're doing wonderfully, and excited to do another one of these talks with you guys. So today will be all about hydrocarbons and inhalants. So let's get started. I have no conflicts of interest. Briefly, as with past lectures, we'll discuss some of the mechanisms of toxicity for hydrocarbons and inhalants, clinical presentation, as well as some keys to clinical management. And outline what we'll talk about. There's a lot of overlap between these categories, and so it is far from rigid, but generally speaking, we'll talk about the hydrocarbons, how those are classified, and how they present. Inhalants, which includes, frankly, a lot of hydrocarbons. Terpenes, which again is also a category of or a subcategory of different hydrocarbons. We'll talk specifically about some of the moth repellents, and then we'll talk very briefly at the end about adhesives, glues, um, to wrap it up. So to begin with, we'll start with the aliphatic hydrocarbons. And for some nomenclature of what makes an aliphatic hydrocarbon an aliphatic hydrocarbon, the way I think about it, I'm not a chemist. I think about them as hydrocarbons, where it's a compound with greater than one carbon atom connected together with a bunch of hydrogens coming off of those. And the aliphatics are not aromatic, is the way I think about it. And so aromatic hydrocarbons, these are the base unit for those is that benzene ring, which we'll see a picture of here in just a few slides. But it's those cyclical six carbon structures with those double bonds that have the resonance structure. And so that is the base of the aromatic hydrocarbon. And the ones that don't look like that, generally speaking, are aliphatic hydrocarbons. They can take a number of different shapes. They can have a huge amount of different variety based on their structure, based on the functional units that are hanging off of them, all that kind of stuff. But you can see, as is shown on the screen, you can see linear aliphatic compounds, branched compounds, as well as cyclic aliphatic compounds. So a lot of different ways to break this out and a lot of different unique chemical characteristics, but this is the basis of it. These are present in daily life. They're present industrially. They're really ever present. And so this is a chart that comes from Goldfrank's, our core text for medical toxicology. And I think it's got some helpful information here, but it starts with kind of a reminder of just how ever present they are. So the basic components of things like gasoline, naphtha, kerosene, turpentine, you name it, these are all aliphatic hydrocarbons. And often a lot of these are kind of a mix, a blend of different aliphatic hydrocarbons combined together into a single product. I like this chart so much because of this column on the right-hand side that shows the viscosity. And this is the most important physicochemical property for the aliphatic hydrocarbons because this viscosity, the really low viscosity for most of these, and the thin nature of these liquids is what informs their primary mechanism by causing toxicity, which is aspiration. So for context, I know these numbers, these Sabalt unit numbers don't mean an awful lot on their own, but for context, the Consumer Product Safety Commission back in 2001 issued a rule that required child-resistant packaging for products that contain 10% or more of hydrocarbon by weight if they had a viscosity less than 100 for this SUS. And so, for context, these are all very commonly seen hydrocarbons. We know them, and they are all demonstrably below that 100 threshold. So, all of these hydrocarbons, these really thin ones, are going to be at high risk for somebody having an aspiration event if you were to ingest it. That's not to say that every aliphatic hydrocarbon is really thin. Clearly, you can see heavy fuel oil, really thick, gunky stuff that is as thick as could be, and obviously would not carry that same risk. So not every hydrocarbon necessarily contains that risk for aspiration, but certainly a lot of them do. So we talked about aspiration being the main thing that we are concerned about when somebody ingests or is exposed to an aliphatic hydrocarbon. It really is the aspiration more than any other systemic toxicity. The main thing we are concerned about here are the lungs. And so aspiration pneumonitis is the condition that we get most concerned about. And this is how it generally presents and how it generally progresses. If somebody's had an ingestion of a really thin hydrocarbon, and they aspirate on some of it, generally speaking, they should have some early symptoms right away: coughing, gagging, choking, vomiting, you name it. That should happen pretty much immediately. It could potentially be a little bit delayed minutes, but it shouldn't really, almost never functionally. It's going to be delayed really much beyond that. So the symptoms should be fairly early. It should be fairly demonstrative if they're going to ultimately go on to develop more substantial symptoms. After that initial aspiration event, then eventually the hydrocarbon gets down into the lungs. We'll talk about the pathology of this in just a couple of slides. But as they get further down into the lungs, causing injury to the lungs, that's when you start to develop more substantial pulmonary toxicity. And patients can come in with bronchospasm, bad wheezing, crackles, rhonchi, or they can develop more substantial respiratory distress, tachypnea, hypoxia. And in really severe cases, it's not unheard of to see development of things like ARDS. Ultimately, this, for the most part, most of these patients, even those who ultimately get a little sicker, most of them will still get better. Happens over the course of several days, can take a week, and it's not necessarily right away, but death is ultimately rare. However, we're talking about this. This is an important topic and gets multiple slides on this review. Of course, because aspiration pneumonitis from hydrocarbon ingestion is still a cause. I mean, again, this is largely a pediatric population from these exploratory ingestions, and so it is a cause of pediatric death in toxicity or toxicology. So it's certainly something that we need to be well aware of and have a good sense of how to risk stratify and triage these patients when we get these calls. This is a slide that shows a potential progression of chest X-rays after an aspiration event from a hydrocarbon. In the top left, that's on day one. After an aspiration of a hydrocarbon, you can look at that and say, it's relatively okay looking, maybe some early inflammatory changes, but the lung parenchyma, I don't know, looks okay to me. On figure B or on image B, you can see that things are certainly progressing pretty substantially. And here we've got bilateral diffuse patchy alveolar infiltrates. And so looking now pretty inflamed. And this is clearly the picture of somebody who's getting quite ill. And then as you progress even further, this is now moving on to day 6, where there is a more focal consolidation in the right lower lobe. And so it's continued to evolve and continue to progress over time. Important to say that the findings on the X-ray are characteristic that they would lag a bit clinically. It's very possible that even in the setting of this X-ray done on day 1, that this kid was actually potentially quite ill, even though they had that reassuring X-ray. And so the absence of X-ray abnormalities, if the kid is sick, doesn't necessarily mean they're not going to go on to bloom something more substantial down the road. I mentioned we talk about the pathology. Here it is. It's all comes down, at least in our general understanding of hydrocarbon pneumonitis or aspiration pneumonitis. It's primarily disruption of our surfactant and disruption of our ability to keep our lungs expanded. So surfactant is made or comprised of these micelles, these lipid bilayers, which help to kind of stent open the lungs by decreasing surface tension within the lungs. The hydrocarbon, when it's aspirated, it will come in and kind of wash out and disrupt the structural integrity of the micelles, and so it disrupts the action or the function of the surfactant. And when it does that, you then drive up your surface tension within your alveoli. They can collapse down, and then of course you are no longer able to functionally exchange gases. And so that's when patients become profoundly hypoxic and have all sorts of respiratory problems from there. I think it's worth saying that we don't necessarily know exactly how all of this happens. I think that's maybe an oversimplification of what's going on. There's some cases that are described of hydrocarbon actually ingestion, so not the hydrocarbon coming directly into the lungs, but the hydrocarbon being injected and ultimately still developing significant pulmonary pathology. Perhaps that's still secondary to surfactant disruption, but it's seemingly a different route. So there may be some primarily just inflammatory processes that contribute to this as well. But certainly when I'm thinking about how these patients are getting sick, the first thing that I'm thinking about is surfactant disruption, collapsing down of the parenchyma in your alveoli, reducing that space, that surface area that you have for gas exchange, and developing your hypoxia from there. So this slide is admittedly enormously busy. I have no intention or expectation that anybody would take even a moment to try to memorize what's on here. It's not worth your while. But the reason I include it is kind of twofold. One, it's from what I think is the most impactful publication that informs our most of our probably triage decision making for how do we take care of these patients and select which patients need to come into the hospital. And two, it also, I think, demonstrates, I think, fairly concretely kind of what the expected courses of these patients are. And so it serves as a nice anchoring example of kind of what you can anticipate when these patients when they come in. So this is a study from 1981. I'll talk about it with some depth, but again, not points to memorize by any means. So it was from 1981. They look at 950 kids who had called into or come into a hospital with a hydrocarbon ingestion. Ultimately, 800 of these kids are sent home, and 150 of these kids are hospitalized. And so what you see here in the chart is 150 of the kids who were hospitalized. One of the top line numbers is that only 12% of the kids of that 950 person cohort developed either respiratory symptoms or an abnormal chest x-ray. That means what, 88% of them were completely asymptomatic with normal x-rays. So the vast majority of these patients who have a potential hydrocarbon exposure do just fine. And that's good news off the bat. Doesn't get us fully out of the woods, but we can take some heart in that. The next thing I want you to take a look at is that bottom row. So that's the bottom half of this is the patients who come in asymptomatic. The good news is the vast majority of them do quite well. 71 kids came in asymptomatic. Only 4 kids in total developed symptoms of any kind where they required hospitalization for their symptoms. And all 4 of those kids actually were asymptomatic at the end of 24 hours. So, not substantial, progressive, really severe symptoms. These kids did pretty darn well. So, coming in asymptomatic, you can take some heart. Doesn't necessarily mean that they don't need some degree of observation down the road. They may become symptomatic in that next observation period, but for the most part, they do pretty good. So that's good news. To swing it to the kids who are a little sicker, we're looking at these 79 kids at the top who come in symptomatic. So usually either the initial or the 6 hour X-ray, actually across the board, these were functionally always abnormal. You either had symptoms or you had an abnormal X-ray within that 6 hour period of time. So you knew you'd have something going on in that early period of time. About 18% of the kids who came in symptomatic had a progression of their symptoms, so certainly a bigger chunk than what we saw with this asymptomatic group. And for half of them, the symptoms resolved within 24 hours. Ultimately, they find 7 total kids who had more complications, and 2 kids in this cohort unfortunately did die. So, again, the takeaway is severe outcomes are uncommon, maybe even rare is the right term, but they're not never. And so it's important to keep these things in mind, these kind of studies like this in mind for thinking of who do we need to hang on to, who do we not. And so a couple of the top line points of this slide is if you come in asymptomatic or you're asymptomatic for a period of time after your ingestion, you're almost certainly going to do just fine. And it's even a select cohort of the patients who are symptomatic on presentation who ultimately go on to get sicker. So how do we assess these patients when they come in? Well, if they come in really symptomatic, and I'm talking wheezing, crackling, hypoxic, tachypnic, hyperpnic, increased respiratory effort, things like that, these patients are coming in. Full stop. They all got to need to be admitted to the hospital. And I would generally argue for a hospital with some ICU capabilities because there is the potential for progressive symptoms when they're admitted. Not necessarily like one of those things where what you see is what you get. They can get sicker over the course of 24 or 48 hours. And so if they come in, they're looking not great off the bat, you need to think about getting them to a hospital where they've got capabilities of taking care of sicker kids. And again, applies to adults as well, but again, it's generally a pediatric population that we're thinking about. If they're asymptomatic, when they come in, an X-ray at the beginning is optional. What is shown in that last graphic is that the abnormalities, present or absence on that first X-ray didn't really predict what happened down the road. And so you don't have to get an X-ray right off the bat. But generally speaking, it is the right thing to get an X-ray at the end of your observation period. Ultimately, patients who have either substantial symptoms during their 6 hour period of time or have an abnormal X-ray, those patients should be admitted to the hospital for further observation. Even then, a very small select subset of those patients, if they're coming in asymptomatic, the vast majority of them do just fine. So a very small subset of them will go on to have any major problems, but we know this is a pathology where severe outcomes are a possibility, and so that's a conservative take. How do you treat these patients? I wish I had bolded, frankly, that top line, the no role for GI decontamination. I would say it's contraindicated after hydrocarbon ingestion. The last thing you want to do is have them starting to vomit, and then they are re-exposed to their hydrocarbon and have the potential for more aspiration. So, A, it's not going to do anything. This is a liquid. It's really thin. It's rapidly absorbed. If it's, whatever it's going to do, the primary issue is what it's doing as it passes by your trachea. And so deconning them when you're not at all concerned really for substantial systemic effects, it makes no sense and it's not to their benefit. You then want to treat them supportively. So reversal of hypoxia, giving them supplemental oxygen, positive pressure if they need it, intubating them if they need it. Bronchodilators are important for those who are giving you signs and symptoms of airway reactivity. And then important to say that there is no role for antibiotics and steroids. It has been studied multiple times. No clinical effect, no clinical benefit derived from somebody who has an aspiration pneumonitis. That's why I say the word pneumonitis multiple times. It's not pneumonia. This is pneumonitis. You'll see, as if they're developing an inflammatory response early on, perhaps they're developing some fever. It's not an infection, it's a pneumonitis. So it can maybe be challenging to fully parse it out, especially if you don't have a great history. But if you know the story, if you got a good sense that this is truly an aspiration pneumonitis, there is no role for steroids, is no role for antibiotics. So with that, we'll leave the aliphatics. Really, it's a pathology of aspiration and thinking about their respiratory injury that they can ultimately sustain, and how do you manage that? So that's the way to think about the aliphatics, and not as much to say about them from other organ systems or systemic injury or poisoning. That's a different story for the aromatic hydrocarbons. And so I mentioned earlier kind of what makes the structure of an aromatic hydrocarbon. That structure on the left, that's benzene, that's the core subunit or the base unit or the building block of all the aromatics. And you can see a couple of other aromatic hydrocarbons in the middle on the right. In the middle, that is toluene. We'll talk about it. And on the right, we'll talk about that one as well. That's naphthalene. And so there's a zillion different permutations. You had different functional groups, aromatics, whatever, or sorry, not aromatics, halogens, alcohol groups, whatever. You can change this a zillion times. And so it's a broad and diverse group, but they're all based on that core central benzene structure. So we'll start by talking about benzene itself. Again, this is the backbone structure for all the aromatics. Commonly, you're going to see this in industrial capacities, either as a solvent or as a precursor chemical, for the production of all sorts of myriad things. This is the teeny representation, but plastics, resins, nylons, rubber, you name it. Benzene's a core starting block for a lot of those. A couple of important things to say about benzene. One is that it is hemotoxic in the setting of a large or acute exposure. You can think about hematologic injury, things like acute hemolysis, aplastic anemia, although that would potentially be after a more chronic exposure. And then I have AML on there. AML, frankly, you can put into the next one as well. This is an IARC1. And so I don't necessarily think of the IARC categories as being a real area for substantial questioning on the C-SPI exam, although certainly discussed with those who've taken it more. But so I don't necessarily look at this as really potentially super high yield, but it is benzene is super notorious for being carcinogenic. And a lot of the blood-based cancers is where you're going to see your problems. CML, AML, multiple myeloma, myelodysplasia, lymphoma, known causative for those bloodborne cancers. So that's a really important takeaway from benzene. It's probably the takeaway from benzene. Industrial exposure, person developing a malignancy, a blood-based malignancy, I would be thinking about benzene for sure in that scenario. The next aromatic hydrocarbon that I'll mention here is phenol. And so this is, for very similar indications. It's commonly, or at least in the past, historically, has been used as a disinfectant, also used as a chemical intermediary. It has more caustic effects than benzene or otherwise you might think of. And I bring up the caustic effects because it always kind of surprised me that it would sit into that category because it's not an acid, it's not a base the way you think about when you're talking about caustics more broadly. But it does have direct irritation and caustic effects and is known to cause esophageal and gastric injury in the setting of large quantity or high concentration oral exposures. There are beyond the local and direct effects of causticity, there's also some systemic effects reported to see things like seizures, CNS depression, and then some kind of nondescript cardiac effects, the tachycardia, bradycardia, etc. If I was going to take two things away from phenol, I would take away kind of the surprising causticity is one piece. The other thing I would take away is how you decon this. It's a little bit atypical, and atypical things I think make good board and exam review type of questions. So it's actually been studied multiple times. The classic way you decon phenol in order to get it to adequately irrigate it off is with a low molecular weight polyethylene glycol. That's what's there on that bottom line on the slide. This has been studied a couple of times in the last several years where instead of using the polyethylene glycol, instead water or saline or even like a high molecular weight polyethylene glycol is used in the same degree of irrigation and elimination of phenol has been seen. So whether or not this is true in clinical practice, like if you're taking care of a patient on the phone, they say, I've only got water and I've just got a big dermal exposure to phenol, get them to use water. That's great. But if you have the opportunity on a test and they say, large, dermal phenol exposure, skin's really irritated, what's the appropriate decontaminating agent? Perhaps what they're trying to push you toward is that low molecular weight polyethylene glycol. So a one-off, clinically maybe of questionable utility, but potentially some board fodder. There is an awful lot more to say about the aromatic hydrocarbons. We're going to move on to a different section for now, though, because those are the only two that kind of didn't fit within a different category. But you will see more aromatic hydrocarbons coming up with some of these subsequent groups. For now, though, I want to move into a new section and talk about the halogenated hydrocarbons. They are what they sound like. It's a hydrocarbon with a bunch of halogens attached to them. What you see here is a couple of chlorinated hydrocarbons. And so what you're looking at on the left is carbon tetrachloride, and what you're looking at on the right is vinyl chloride. So a couple of really notorious halogenated hydrocarbons. I don't have a slide specifically on vinyl chloride because it seemed a little bit less likely to show up, and you can pick these ad nauseum, these different potential agents. But I want to talk about some of these examples specifically, and then I also want to get you some themes about the halogenated hydrocarbons and kind of how to think of them, because eventually this turns into this, I think, a painful exercise in remembering these one-off toxicities from a bunch of these esoteric kind of chemicals. How can you lump them a little bit and get some thematic trends from this? And so we'll talk a little bit about that as we go. So we'll begin with the, I think probably, I think probably the most important of the bunch and the most likely to be testable of the bunch, which is methylene chloride. Why is it the most likely to be tested in the bunch? Because it's weird and it has a really kind of fascinating toxicologic manifestation. So dimethyl chloride, or sorry, I said that backwards. Dichloromethane, or methylene chloride, it is metabolized in the body by varying cytochrome oxidases and other transferases, etc. But when it's oxidized by cytochrome oxidases, what one of the important toxicologic metabolite is there in the red box, which is carbon monoxide. And so again, that is absolutely, I think, testable. It's interesting. It's important to know clinically, as of course, as well. But this is just asking for a question, I would think. So really important, I think, this to lock that little fun fact away. So methylene chloride, it is metabolized to carbon monoxide. The parent compound itself is also got some caustic components. There's a case series of defatting dermatitis, GI injuries, things like that. And so there's other things to keep in mind with dichloromethane or methylene chloride, same compound. But ultimately, what they would test you on is the fact that dichloromethane is metabolized to carbon monoxide. The thing is to keep in mind with this is if somebody comes in after a big dichloromethane exposure, they drink a whole bunch for whatever reason, um, you don't want to get rid of them right away. They have the potential for development of a delayed carbon monoxide production, and that's on average in the neighborhood of 4 to 8 hours post exposure. And once it's developed, there's also a prolonged apparent half-life. And so in the neighborhood of like 13 hours. So it looks very different. The timing looks very different than any other scenario where you're thinking about CO, where it's always, I've been exposed to this gas, I've got symptoms right away, and then you're working on getting them down from there. This takes a different category where they may come in theoretically without symptoms, without carbon monoxide, but then produce it kind of before your eyes and develop some delayed toxicity. So if you get this picture of somebody is exposed or drinks a large amount of a paint stripper, this is the classic use for dichloromethane is in paint stripping. They're exposed to it. 4 hours later, they've got a headache, they've got some ataxia, some CNS depression. You better be thinking about carbon monoxide. That's and this being methylene chloride is the causative agent. So that one is very testable, and I would certainly lock that one away. Another one that comes up an absolute ton historically in toxicology. I think this is an important one, although maybe less relevant in the day-to-day clinical environment, is trichloroethylene. So TCE, it's a really important compound, and a lot of historical import for TCE. Primary use is as a metal degreaser. Previously, it was used as a dry clean agent. Now all of these chlorinated hydrocarbons are being phased out, and there's other agents that are being used that are much safer with less problems associated. But historically, that's one place where it was used as well. A couple of, again, I bring this up because it's just got these weird one-off things, and weird one-off things are sometimes real testable. So some of the one-off things for trichloroethylene, one is this degreaser's flush. So if you get a clinical scenario, somebody's been using a metal degreasing agent, they then go and drink a lot of alcohol and they develop what sounds like a disulfiram reaction with a lot of headache, flushing, nausea, vomiting, vital signs are abnormal, hypertensive, tachycardic. That is from TCE, that is from trichloroethylene. The mechanism of this is that trichloroethylene seems to impair or inhibit aldehyde dehydrogenase. the exact same way that disulfiram inhibits aldehyde dehydrogenase, which is why TCE can lead to that disulfiram reaction. You can get that clinical scenario. So something that I think is also pretty testable and something worth putting away. It's associated with some other things as well. Some trigeminal neuralgia is another kind of picture, and then some degenerative diseases. And then this number four there, that fourth bullet point, it is, I'd say, the hepatotoxicity, the nephrotoxicity is not something that's necessarily specific to TCE. With the chlorinated hydrocarbons, broadly, broad strokes, you'll see it on the next slide as well. There's a lot of hepatotoxicity with these. And so if you are ever stuck in the weeds or some hydrocarbon exposure and a liver injury, pick something with some chlorines and some carbons, because the chlorinated hydrocarbons broadly, there's different degrees of impact to the liver and things like that, but I think of liver injury being strongly associated, or different liver diseases actually, with the chlorinated hydrocarbons. So it's kind of a trend, a bit of a theme amongst this entire class. The last one I'll talk about, this is the major way in this that carbon tetrachloride causes problems, is liver injury. So carbon tetrachloride, not something you're going to see around all that much anymore. Historically, a solvent, it used to be a refrigerant, has been phased out because of emissions. Historically, as a fire suppressant, it was in these amazing looking fire, what are they called? Fire bombs or fireballs, where these glass balls with just filled with carbon tetrachloride. The problem with carbon tetrachloride also undergoes cytochrome metabolism. As it undergoes cytochrome metabolism, you can see right in the middle, it produces these free radicals. These free radicals cause a lot of liver injury. Now, if you look at the enzyme responsible for metabolizing carbon tetrachloride, or if you want to sound cool, you can call it carbon tet. If you look at the enzyme responsible for metabolizing carbon tet to that free radical, it's CYP2E1. If you think back to acetaminophen, its primary oxidizing enzyme is also CYP2E1. So the reason this causes liver injury is that CYP2E1 is present in high concentrations in that certain zone of the liver. That's where carbon tetrachloride gets metabolized. That's where it then produces its free radical, and that's why it causes liver injury. So these patients, excuse me, can really develop a profound liver injury, massive elevations in their transaminases, things to that effect. Also, some nephrotoxicity, and it's a suspected carcinogen. But if you were to get a story, if you were to get a picture where it's a carbon tetrachloride with some liver injury, it'd be a good opportunity, or a thought would be thinking about providing different antioxidants and things like that. And probably acetylcysteine would be another way to go as well. All right, moving on from the chlorinated and halogenated hydrocarbons, we'll go into inhalant abuse. This is a slight departure away from the hydrocarbon itself, but again, there's a ton of overlap in between these sections. You're going to see a lot of structures and a lot of the themes from prior sections kind of showing up here again. So it continues to blend a little bit, but in this section, we're really going to be talking specifically about inhalants, ones that are abused and used for recreational purposes, and some of their toxicologic manifestations. First one we'll talk about is toluene. So it has largely replaced benzene as a solvent. It unfortunately is chronically abused as an inhalant. There are a couple of really classic manifestations from chronic use of toluene as an inhalant. The first is leukoencephalopathy. So there's some characteristic white matter changes that you can see on an MRI for somebody who has been chronically using toluene and has some of these neurological manifestations. And so the way that they'll present, you can have ataxia, spasticity, dysarthria, dementia, paralysis. You can really start to develop some absolutely debilitating and life-altering neurological manifestations from the chronic use of this, unfortunately. The other thing that can come up is a renal tubular acidosis. And so that's kind of the characteristics of it there on the description below, this hyperchloremic, hypokalemic metabolic acidosis. These are non-GAP acidoses. And so if you find yourself, this I think would be a bit next level, but not impossible. If you find yourself looking at somebody who's got an acidosis, their anion gap is normal, they're a chronic inhalant user, certainly be thinking about toluene. That would be the first place that my brain would go, is thinking about a possible RTA from toluene. It's also known to be teratogenic as well. The next we'll talk about is Freon. And so this is the fluorinated hydrocarbons. Most of these products, so these are propellants. The goal is to just make stuff come out of a can real fast. And so difluoroethane, tetrafluoroethane, difluoroethane being the one that you're going to see the most in a lot of these dust off products and things like that. are also unfortunately used for inhalational and recreational purposes as well. From an acute toxicity standpoint, the main thing that you'll see is just CNS depression, but a couple of other more specific things that I think would tip me off that they're using a fluorinated hydrocarbon like Freon. The first is the possibility for oropharyngeal burns comes out real cold, so you can develop frostbite burns, thermal injury to the mucosa, to the upper GI tract, things like that. The other thing that will come up is the potential for this condition called sudden sniffing death, which I have a bit more information on here in just a bit. But this is this other kind of scenario where actually, here we go. This other scenario in which somebody has been using a halogenated or fluorinated hydrocarbon. They've been inhaling it. And the concern is that this fluorinated hydrocarbon, like DFE or difluoroethane, is going to what's called sensitize the myocardium. And the way that it's sensitizing the myocardium is by blocking the inward potassium rectifying channel. That's the channel that is responsible for myocardial repolarization. And so that's this QTC segment on the EKG. And you wind up with a prolonged repolarization phase on your EKG. And that puts you at risk for dysrhythmia. And the classic story for this is I'm a person who's using a bunch of my inhalant. In this scenario, things like a difluoroethane, although frankly, toluene is associated with this as well. I'm using my inhalant, and then all of a sudden I'm startled. Perhaps I've been caught by the police and I've got this jolt of catecholamines. Perhaps parents walk in on me while I'm using my difluoroethane, and again, I get that jolt of catecholamines. That jolt of catecholamines precipitates a dysrhythmia because I've got this primed myocardium, and all of a sudden I'm off to the races, and now I'm in this wide, complex tachydysrhythmia. That's an important thing to diagnose and recognize as a risk for these patients, in that they have the potential for developing these wide complex tachycardias, and that's the most likely or the best understanding of its mechanism. The second is to recognize that these are catecholamine dependent dysrhythmias. And so if this person comes in and they're markedly hypertensive or they're in cardiac arrest, they're going to get a ton of epinephrine. And the fear is that all of that epinephrine will actually potentiate the problem that they have going on. And so this is one of those times where in sudden sniffing death, you get this person is in, they've been using a bunch of difluoroethane or dust off, they've been using a bunch of toluene, they come in a wide complex tachycardia, and all of a sudden they're getting standard ACLS. It might be one of those times where you're saying, perhaps I need to pull for a different type of medication, and thinking about actually beta blockade. So instead of using catecholamines, you may be thinking about beta blockers. The classic one that we're using in an arrest scenario is something like esmolol. And so I would think about, if you get this type of scenario and they give you a couple of options of what the next medication you want to pull is, you might want to think about, do I need to pull, or think about a beta blocker instead of the standard catecholamine that ACLS would prompt me to pull. And I apologize, I jumped ahead just a bit. I realized my slides were slightly out of order. But to take a half a step back, there's also some chronic problems that are associated from these fluorinated hydrocarbons as well. And I bring this up because I think it's just some really impressive radiographic images. This is a condition called skeletal fluorosis, where the chronic exposure to these fluorinated hydrocarbons leads to hardening of the bones, deposition of these ions into the bones. And so you get really significant calcinosis of the bones, of the tendons, can lead to bad arthritis, decreased mobility, decrease in joint movement, arthritis, and things like that. But also, because of the excessive hardness of the bones, you can see increase in bone fragility because it lacks that elasticity. And so these patients are at increased risk for fractures. So bad arthritis, pathologic fractures, things like that are a possible outcome in the setting of chronic use. Of course, this is not something that happens right away. It takes chronic use. All right, so apologies for the slides being out of order. And then moving on to the last couple of inhalants, this is where we depart the hydrocarbons altogether. Well, with the next one, we're making our way out of the hydrocarbons here, but this next one is the alkyl nitrates. So the ones that you will potentially be thinking about or more likely to see is things like amyl nitrite, isobutyl nitrite. Classically, these are going to be known as poppers. These are short-lived in effect. They cause euphoria, smooth muscle relaxation, disinhibition. They're commonly used for chemsex, both because they potentially have some libido-inducing properties, and they'll decrease inhibition for those who are looking for that. The mechanism not fully understood, but it's primarily via vasodilation. As it's metabolized, you release nitric oxide, and then you have peripheral vasodilation. Why do we talk about this with toxicology? I doubt I have to tell anybody on the other end of the computer. But the thing that we're thinking about with nitrites is the potential for methemoglobinemia. These nitrites are profoundly oxidizing. They oxidize your hemoglobin from hemoglobin 2 plus to hemoglobin 3 plus or methemoglobinemia, leading to methemoglobin. So I'm not going to talk in depth about the physiology or the pathology of methemoglobinemia. There's a separate talk for that, and we've got other stuff to get into as well. But of course, if you see somebody presenting after a popper exposure, an amyl nitrite exposure, you certainly want to be thinking about methemoglobinemia if they're showing you signs of being blue or dyspneic or whatever. And the treatment, assuming no contraindications, would be methylene blue. Into the final of our bunch for the inhalants, we're going to talk about nitrous oxide, so N2O. Where are they? Well, they're medically used. Of course, we know that they're great for sedatives and for short procedures. But they're also present as part of food products and are used recreationally. The term that's applied most commonly is whippets. So how do they work? They actually have a little bit more known about them than some of these other prior ones as far as their euphorogenic properties, and it's via largely through NMDA inhibition, so same kind of mechanisms as things like ketamine, but also known to stimulate dopaminergic neurons. From a toxicity standpoint, beyond just general CNS depression and euphoria, etc., from a toxic standpoint, the reason why somebody might die from this immediately is just a straight up displacement of oxygen, simple asphyxiation. There's some really, really sad and devastating cases of this, and there's different ways of using this, as well as, frankly, all of these inhalants. There's a number of different ways in which these inhalants are used, in which people can try to really ramp up the concentration of them that they're receiving. Some of the more dangerous, I think fairly intuitively ways are by which people put like a bag or some kind of a hood over their head. They then fill that hood with whatever their inhalant is, nitrous oxide in this case. And as they do that, very obviously they're displacing oxygen. And if they don't have a buddy around them, or if their buddy is impaired in some way, as they displace oxygen, very obviously they can lose consciousness since they have a non-breathable object over their mouth and over their face that leads very clearly to the potential for asphyxiation. So that's the way that somebody can die from this. It does happen. It's a tragic thing when it does, but that is the mechanism for that. Chronic use has some differences and something that's a little bit more worth talking about at some length. So it's got its own separate slide. So let's talk about chronic nitrous oxide toxicity. It's kind of interesting. So the mechanism by which this happens is that nitrous oxide will oxidize the cobalt moiety in vitamin B12. And when it does that, then B12 does not participate in a couple of really key chemical reactions. The first, when you're looking at the homocysteine methionine pathway, that's the loop that's over there on the left, is that if B12 is no longer functional, then you no longer have a functional methionine synthase. You can no longer convert homocysteine to methionine and eventually for the production of S-adenosyl or adenosyl methionine. Why does that matter? Well, that final product, that S-adenosyl methionine, is required for maintenance of our myelin sheaths. And so if you're not able to continue to maintain your myelin sheaths, then ultimately what you're left with is demyelination and neurological injury. And that's very problematic, and it manifests actually quite severely in a number of these cases, where if you're starting to develop myelinopathies, you can start to see numbness and tingling. I'd say that's most common. But it can progress to becoming quite severe, where you can see ataxia and gait disturbances, urinary incontinence, paralysis, to the point where people can be long-term wheelchair bound and really have a substantial loss in function. So clearly these are manifestations that you're going to see in chronic use. And also because we're talking about folic acid recycling and things like that, there's also implications in red blood cell maintenance. And so you can see a megaloblastic or a macrocytic anemia would be the other takeaway for this. But there are going to be findings that are going to be present in chronic use, not like one single use where you're going to develop this, but they can be quite debilitating. The treatment, the only thing that we have evidence for, or that we can say with confidence is going to be the right thing to do, is to stop using a bunch of nitrous oxide. However, there are recommendations that exist to try to supplement these dysfunctional proteins as best you can or these dysfunctional, not proteins, but vitamins and other molecules as best you can to reconstitute the action of these processes. So giving them back methionine, giving them back B12 is rational, even if we lack really good evidence to say that it's going to be effective. So you get them to stop using their nitrous oxide, you supplement the things that are probably lacking in them, and then just continued follow up is going to be their care. But they can have some pretty considerable manifestations. So moving on from our inhalants and on to the terpenes. So broadly speaking, terpenes, they are built from these isoprene building blocks. So just like the aromatics, they all come from benzene. The terpenes are all built from these isoprene building blocks. These are volatile hydrocarbons and they're all derived from plants. And you're going to see these often in essential oils, cleaning products, fragrances, etc. They're quite ubiquitous. Some examples, we'll talk about a few of these. The camphor, pine oil, pennyroyal, thujone are going to be the ones we talk about because they've got maybe a bit more to say from a toxicological perspective, but there's some things that can happen with some of the other ones as well. So to get into, I think the biggest and most important of the bunch is camphor. Where are you going to see it anymore? Well, it's used primarily as a topical rubefacient, and so it's topical pain relief. So you'll see it in things like Tire Balm. You'll also see it in things like Vicks Vapo Steam and Vapo Rub, because it has that kind of soothing sensation to the upper airway when you've got a cold or whatever. How does that work? How does it do this? Well, they are demonstrated, they're known to desensitize these TRPV1 channels, which is the transient receptor potential vanilloid receptor. Put that into the category of things that nobody needs to know. These receptors or these channels work to help to control our sense of temperature. There's a series of these different channels, and based on which ones are inhibited and based on which ones are active, that controls how we sense temperature. And so there's a lot of these TRPV1 desensitizers that will provide either the sense of heat or the sense of cold based on which of these channels they desensitize. So that's how, generally speaking, the camphor works. In toxicity, what do we need to know? It causes seizures. And it doesn't take an enormous amount. So death is reported after functionally 1 teaspoon of 20% camphor. So it doesn't take much, and you've got to be vigilant that that's the main thing you're looking for. The good news, if there is good news about seizures with camphor, is A, it's not around in these large quantities in these pellets that you see here as mothballs nearly as much because we have much safer options for mothballs. The other piece of good news is if you are taking care of somebody with a possible exposure to camphor, you need to send them in. The good news is that if they're going to develop symptoms, they're going to develop them relatively early. The vast majority of seizures are occurring in the first couple of hours, and you can say with some confidence that if you make it through 6 hours with no neurological effects, that they're not going to subsequently go on to develop a seizure. So they don't need these days of observation is kind of the nice thing. If they're going to get sick, you know about it relatively quickly. But camphor, mothballs, seizures would be the things to lock away. Pennyroyal is the next one to talk about. So also a terpene, used very differently from camphor. Historically and unfortunately still presently, it is occasionally used as an abortifacient. And a term that I learned for the first time as I was putting this talk together in a menagogue. And so it increases blood flow to pelvic and GU structures. And that's probably the way in which it would work as an abortifacient. Its toxin is pulegon, and also like some of the other toxins that we talked about, it acts as a protoxin. It gets metabolized to this toxic metabolite, menthofuran, amongst others, which then causes glutathione depletion, and ultimately that glutathione depletion causes hepatotoxicity. And like other toxins that cause hepatotoxicity, they cause glutathione depletion and hepatotoxicity. The treatment is primarily NAC. So pennyroyal, if you get a case vignette where you've got a person using a home remedy for a home abortion or something like that, and they develop a liver injury, certainly be thinking about pennyroyal and pulegon as being the potential causative agents. Pine oil, again, these are widely present in homes. They're probably in all of my bathrooms here in this house, primarily as a house cleaner or a degreaser. Primary toxicity is as a GI irritant. Most common, though, and the most concerning would be the potential or the development of an aspiration pneumonitis. And they can develop actually some of these, possibly like a lipoid pneumonitis as well. Broadly speaking, you're going to think about these and treat these the same way as you would for your aliphatic hydrocarbons. And so, not an awful lot different to say, although it is reported that there is some degree of more systemic toxicity, things like CNS depression, seizures. They're all reported, though certainly not common. And the major issue that you'd be thinking about for pine oil or turpentine would be the aspiration pneumonitis. And then the last one of our terpenes, we're going to talk about thujone. Where does thujone exist? Well, historically in absinthe. Anymore, it's in like essential oils, oil of wormwood. So absinthe is where it lived historically. It would be in a combination of different liqueurs or whatever. Its mechanism of action is via GABA antagonism. And if you think enough about GABA, which I know you all do, you can recognize that GABA antagonism is not something that is particularly desirable, especially in toxicity. It will cause some CNS excitation, but in overdose, you think about potential for confusion, restlessness, hallucination, and obviously in a big overdose, you can think about seizure. Also worth noting that rhabdomyolysis is also reported. How would you treat this? Well, if they are antagonizing GABA, well, it would probably behoove you to treat with some GABAergic agents. So benzodiazepines for the agitation, delirium, seizures, IV fluids if they are manifesting rhabdomyolysis. And then moving toward the I think the home stretch here. The last few that we have are the moth repellents. We already talked a little bit about camphor. That I think in some ways kind of fits into this category, but again, it has been so largely phased out that it largely is going to be sitting actually more in that terpene category with the essential oils. But these last two have a little bit more history, at least more recently, with the mothballs. Naphthalene is the first one we'll talk about and has easily the more notable toxicologic profile. Historically, has been used as a deodorizer. Largely, it's been phased out by the compound that we'll talk about next. Also, again, it's an insecticide. It's mothballs. It is got some problems that are associated with it. It is a highly oxidative hepatic metabolite that then leads to the potential for hemoglobinemia and hemolysis. Early, you can see these kind of vague, non-specific symptoms: GI upset, lethargy. Possible, it's reported to see seizures, but I would not call that by any means common. The challenge is that you have the possibility, and I have it listed in bold and red, 1 to 3 days out, the possibility for delayed hemolysis, and that jaundice would be an indirect hyperbilirubinemia from the breakdown of your hemoglobin. So not something that's overtly hepatotoxic. That's a manifestation of your red blood cell breakdown. It does not take much to do this. There is report of pediatric patients getting sick after exposure to like blankets and stuff that have been wrapped up with a bunch of naphthalene mothballs. So it does not take very much. And this would be double true in a patient who has a G6PD deficiency, as those patients are going to be at an increased risk already for developing hemolysis. So you add an increased oxidizing stressor to them, and then your problem is going to be compounded. How would you treat these patients? It's really ultimately supportive. We mentioned earlier kind of how to manage methemoglobinemia. If you were to see it, it's going to be with methylene blue. And if they're showing you signs of marked hemolysis, then you would transfuse them as needed for hemodynamics or for perfusion. But the really important thing to take away from this, and I'll reiterate what's present in Olson's, is that you need to have either a plan for a prolonged observation period, or if they look really well, then the discharge planning needs to include 24 to 48 follow-up with repeat labs to make sure they are not beginning to lyse. So it is in stark contrast to camphor, where we say camphor can get real sick. It goes into that one pill can kill, even though we're not talking about pills category. Camphor is no joke. I'm not trying to say that it is, but you know you're sick early on, right? 6 hours, you know if you're gonna have a seizure or not. Naphthalene, also in that mothball category, kind of. But you have this potential for really delayed effects, and that's a huge schism and something that, at least for I recall for our boards being really hammered on as being something that was quite testable. The last one is frankly the most ubiquitous of the mothball compounds between the camphor, the naphthalene, and this one, paradichlorobenzene. It's going to be the thing that you see the most, and that's because it's the least toxic. So there's the least to say about it, frankly. It's largely replaced the other two for these deodorizer purposes. You'll see them in urinals, in diaper pails, whatever. Um, Broadly speaking, it's tolerated really well. It's good news. Acute exposures generally are quite well tolerated, but there is this report in chronic, really high concentration exposures for the development of neuropsychiatric effects, encephalopathy, dementia, things like that. That said, that's very one-off and not something that I think is as core content as some of these other compounds. We talked a little bit about the mothballs broadly and talked about how they're very different. The paradichlorobenzene, I think, is again, I think it's the least germane of the three because it just does not cause all that much of a problem. Camphor and naphthalene cause big problems, though, and the problems that they cause are twice different, and the degree of observation that they need is quite different. So if somebody's got an exposure to mothball, not otherwise specified, you don't know what they've been exposed to. Um, in a case vignette at the very least. I'm not sure that this is going to completely hold true in actual clinical purposes. I've certainly never done this, but from you're looking at a case vignette or something like that. It's a possibility that somebody at some point asks you to differentiate between things like camphor and naphthalene. The way I think about this is so that the largest way, the most common way to try to differentiate between these compounds is having them sink or float in water. The way I think about this is Camphor's got the shortest name, and so it's going to be the lightest of the bunch. Paradichlorobenzene has the longest name, and so it's going to be the heaviest of the bunch. Naphthalene's in the middle, so its weight is in the middle. So how does this manifest? Well, paradichlorobenzene is such a big long name that it's such a heavy compound that it will sink in regular water, fresh water, and it will sink in a really saturated salt water. Doesn't matter how buoyant that water is, it's going to sink no matter what. Camphor, on the other hand, is so light that you can put it in salt water or you can put it in fresh water and it will sink, or sorry, it will float either way. Naphthalene, it's in the middle. So if you put it in fresh water, it's not going to be buoyant enough, it'll sink. If you put it in that really concentrated salt water, it'll float. And so again, that I think would be a very next level question. I'd be a bit surprised to see it show up on the exam, but I would offer that an important thing to try to differentiate between these mothballs if you got an exposure and if somebody thought it was testable. I think this is a relatively easy paradigm to put away. Finally, last slide and last exposure, and not an awful lot to say about it, is the adhesives and glues. There is truly not much to say about it. The good news is in Olson's, it actually calls an ingestion of cyanoacrylate harmless. So superglues, broadly speaking, there's different compounds for some of these different products. They're not all cyanoacrylate, but it's the most common that I was finding. Ingestion, harmless. Ocular exposure, you can certainly think about an abrasion, and if it's really causing ocular injury or bad visual, impairment, it certainly would be irrelevant to have an ophthalmologist be involved. Dermal exposures, if somebody has glued themselves to something that they don't want to be stuck to, the way you can think about trying to get these removed is with using things like acetone or things like petroleum-based ointments to try to get those off. Which I know we have had conversations about in setting of like things like if there's significant protests or demonstrations and people were talking about gluing themselves to the sidewalk in demonstration. What we offered to our first responders is this recommendation here to use petroleum-based ointments or acetone to try to get them removed. So not an awful lot to say. Fortunately, these are otherwise quite well tolerated. So that is a big topic. I think there's a lot of really one-off type of things. And so try to keep in mind as best you can those trends, the chlorinated hydrocarbons. You want to be thinking about liver injury as well as some of the specifics for each of those compounds. For the aromatic hydrocarbons, they certainly cause more systemic injury or issues than the aliphatics. The aliphatics are overall, I think, the easiest to lock away because those aliphatic hydrocarbons, the naphthas, the kerosenes, etc., they're really only going to be impacting the respiratory system, causing that aspiration pneumonitis. So I hope that's helpful. I wish you the best of luck with the remainder of your studies. I'm sure you're doing fabulous, and I'm sure you're on track for great things. And so good luck the rest of the way.